Cystoscopy, also known as cystourethropy, is a procedure that allows visualization of the urethra, urethral sphincter, prostate, bladder, and ureteral orifices. It can be performed either in the operating room or the office, depending on the reason for the cystoscopy and the patient's condition. This procedure also permits minor interventions like biopsies and fluid collections for culture or cytologic analysis. Indications for cystoscopy include patients with gross or microscopic hematuria, the evaluation of lower urinary tract symptoms, chronic pain, recurrent urinary tract infections, and the initial evaluation and subsequent surveillance of bladder cancer and other conditions like fistulas or foreign bodies. The only absolute contraindication is an active symptomatic UTI. A UA is usually required about 5 to 7 days before, with cultures obtained if necessary. Patients with an active UTI must be treated prior, and the sole contraindications to office-based cysto is patient intolerance and limitations in positioning.
Here's our sets. The big things is every cystoscope will have 3 components: the sheath, the bridge, and the scope itself. We have to remember that all of the sheaths will come in different sizes. So here we have a 17, a 19.8, a 21, and a 25 French. You can notice that by looking right at the top. This one we'll look at the 19.8. In the big circle you'll see 19.8. What's useful to know is that when you flip these around, you'll see 3 numbers. This says 5, 5, and 4. The 5 in the middle denotes how big something can get through that's in a single bridge, while the 4 and 5 denote how big you can get into for a double bridge. When we look at the 21, if we reverse it, 6, 7, 5, so through a single bridge you can fit a 7 French, through a double bridge you can fit a 6 French and a 5 French tool or stent. And then the biggest one that we have is a 25. You can see that you can get a 12 French, a 9, and a 6. When we talk about single bridges and double bridges, this is what we mean. So this being a double bridge with 2 inlets, and this being a single bridge with 1 inlet. Scopes can come in different angles, right? And so here we have a 12 degree, a 30 degree, and a 7 degree. They also make a 0 degree, but it's not within this set. For our diagnostic cystoscopies, it's most useful to use the 30 degree and the 7 degree.
There is no standard recommendation sequence in the literature. However, the urologist should employ a systematic approach to reduce the risk of inadvertently missing regions of the bladder. Start with a 30-degree lens and examine the following: bladder neck, both UOs, posterior wall, right lateral wall, dome, left lateral wall. To examine the anterior wall, the scope should be retracted to the bladder neck and apply manual pressure to the suprapubic area. Switch to a 70-degree lens for optimal visualization of the anterior wall and the anterior portion of the lateral walls. The preferred position for performing a rigid cystoscopy is in the lithotomy position. The patient should be placed supine with 80 to 100 degrees of hip flexion, 70 to 80 degrees of knee flexion, and 30 to 45 degrees of leg abduction. The procedure is started by opening the inflow and inserting the scope into the urethra. It's important to visualize the entire circumference of the urethra, maintaining the lumen at the center at all times. We then see the posterior wall. Be cognizant of your inflow and outflow at all times. We then identify the ureteral orifices in the interureteric ridge, the right lateral wall by rotating the lens, the left lateral wall, we then rotate the lens 180 degrees. We can apply manual pressure to the suprapubic area to push the anterior wall towards the lens to identify tumors that are commonly missed or in difficult to visualize regions. And the female urethra is best visualized on exiting the bladder, keeping the center of the lumen at all times. It's very important to control your inflow and your outflow during the procedure, not to over-distend the bladder. We then identify the bladder neck in the interureteric ridge, the left lateral wall. We then see the posterior wall and the right lateral wall by rotating the lens. Notice the arrow on the left side of your screen as a point of reference. We then identify the ureteral orifices. If you're unable to identify one, go to your known ureteral orifice and track across the interureteric ridge to find the opposite in a normal anatomic patient. Thank you.